So good morning. Thank you for invitation. I pre-recorded the presentation, so this will be much better because of the
Okay.
not the technical issues. However, I would like to thank you for invitation to the book and to this excellent presentation. And I will stay for the questions. Okay, thank you. So good morning. My name is Piotr Rutkowsi. I represent National Research Institute of Oncology in Warsaw, Poland. Thank you, Professor Gabriela Liszkaj, for this wonderful enterprise and launching the melanoma book for Hungary, the complex melanoma oncotherapy. I will focus on my chapter related to perioperative therapy in melanoma. This is very complex issue now. Here you see my potential declaration of interest. I'm surgical oncologist who has been treating melanoma and skin cancer patients for more than 25 years in multidisciplinary teams. So this is why I'm biased for perioperative treatment. And we have new recommendation when we look at the stage 2 BC. Of course, now we have approved anti-PD-1 therapy for 12 months. However, still clinical trials is something or standard follow-up what is allowed. And in terms of the positive sentinel biopsy, we do not go further for surgery. So completion of dissection has been abandoned. And now we are using adjuvant therapy with anti-PD-1 or BRAF/MEK inhibitors, dabrafenib, trametinib with BRAF V600E mutated tumors. And for stage 3, clinically detected, we have two options: adjuvant therapy after upfront surgery, lymph node dissection with anti-PD-1 or dabrafenib, trametinib, or neoadjuvant nivolumab, ipilimumab, follow-up adjuvant therapy based on the pathological response. And this is what is also recommended based on NADINA trial. And in stage 4, we can use after metastasectomy also anti-PD-1 therapy. We see also in Poland the changes in the attitude. We also almost eliminated completion in node dissection and introduced in 2021 adjuvant therapy. So it's now 4 years full reimbursement of it. And we also have the data that completion node dissection has no sense. However, the impact of new adjuvant therapy really improves relapse-free survival. Of course, we have some discussion, especially for clinically involved nodes, what should be the sequence. Maybe neoadjuvant therapy will be the gold standard if it will be fully reimbursed, because it may lead to less extensive surgery, maybe more cure, and also the information of prognosis biomarker. But the major issue is collaboration between oncological surgeons and medical oncologists. Why we are using adjuvant therapy? Because, of course, first it was introduced in stage 3, because stage 3 is the first site of metastasis in 50–80% of patients, very heterogeneous group. And you see that 3D, 3C is related to very poor prognosis. 3A is relatively have a relatively good outcomes. However, about 60% of patients in stage 3 has ultimately relapses. In stage 2B to C, about 40% of patients have relapses. This is why these groups of patients are called high-risk melanoma. So adjuvant therapy after surgery now is a standard of care in many high-risk patients. Neoadjuvant therapy is something what has been recently established for clinically involved nodes. What we have for adjuvant therapy in stage 3, we have, of course, anti-PD-1 or dabrafenib, trametinib. In stage 4, only nivolumab. In stage 2 BC, pembrolizumab or nivolumab. Recent development and approval really changed the landscapes of melanoma therapy, of course, in metastatic setting, but also in local regional disease. All trials are also performed after CLND, but now we use them immediately after positive sentinel lymph node, and it dramatically decreased use of relapse and improved distance metastasis-free survival. We haven't data on overall survival, and no formal approvals for neoadjuvant therapy, but it is adapted in some countries as well. So how we can use it, of course, for BRAF positive after resection. You may see that for stage 3 disease, we have all options for stage 2B and 2C. Additionally, we have anti-PD-1. In stage 4, we have nivolumab. It is based on the several trials showing the improvement on relapse-free survival and distance metastasis-free survival. Here is for dabrafenib trametinib, here is for nivolumab, here is for pembrolizumab. And generally, it decreases about the relapses in about 15 to 20% of patients. So when we look at the guidelines, NCCN guidelines showing that this is category 1, and after positive sentinel lymph node, we are going directly to systemic therapy with adjuvant therapy. With clinically stage 3, we can option of neoadjuvant therapy or surgery and adjuvant therapy. For stage 2B to C, pembrolizumab and nivolumab are also valid options. When we look at the long distance data, of course, the curves are really in parallel. So we have the stable situation and decrease of relapses. Distance metastasis-free survival, you see that this is 17% difference at 5 years for pembro. So it's really important. However, it also depends on the substage of melanoma. It's the lowest difference for stage 3A. It's the highest difference for stage 3C, 3D. So more advanced disease, more difference, the same as from COMBI-AD for dabrafenib trametinib. Generally, number needed to treat patients for adjuvant therapy for the benefit in distance metastasis-free survival is 6. And when we look at our data from Poland, you see that we also performed multi-center study. And during first 2 years, it's a huge impact of BRAF-MEK adjuvant therapy over anti-PD-1 therapy, but it crosses after 2 years. And no completion in no dissection. Of course, the number needed to treat and number needed to harm are important in terms of the impact on the final results in and the number of treated patients to achieve the benefit. And of course, even if absolute benefit HR is 0.5 here, so absolute benefit here is 25%, and this is what we got for in general for stage 3 disease. However, in some substages like stage 3A, although HR is still high, but the absolute benefit is only 5%. So it really raises the questions, should we use this adjuvant therapy in this population? For stage 2B to C, we have 2 studies. One is for pembro, another is for nivo, and especially in substage 2C, the difference is really high. It's 12% improvement of distance metastasis-free survival. This is for nivo, and the curves are similar. However, the number needed to treat is a little bit higher, about 7, 8 for stage 2. What is also important, the number needed to harm is about 3, and for grade 3 or higher treatment-related adverse events is 8. What can be the future is introduction of mRNA personalized vaccines, so individualized immunotherapy, neoantigen therapy. When we remove the tumor, we prepare the neoantigen-based mRNA vaccine. We start pembro and adding this mRNA. Until now, we have results from phase 2 trial, and if improvement for RFS is amazing. You see here, it's 16%. However, for distance metastasis-free survival, if even better, because final results we have at the level of 90%. The recruitment for phase 3 trial has been finished. So it means that next year, probably with the results, and maybe it will be the new standard of care. What can we use also? We have data from real-world evidence that targeted therapy, especially in the shorter period of time compared to anti-PD-1, more significantly reduce the risk of relapse in adjuvant therapy in stage 3 disease. So this is one of the preferable options, especially that it does not induce the resistance to EP-Nivo and sensitivity to Nivo-EP when the patient have relapses is still saved. So it means that we can treat the patients in metastatic disease with the combination. Another study showing the same phenomenon from real-world evidence that especially for relapse-free survival, dabrafenib, trametinib overcome the results from anti-PD-1. So to summarize, adjuvant therapy, we have 3 approved systemic therapies: pembrolizumab, nivolumab, dabrafenib, trametinib, from stage 2 to stage 4. The goals of adjuvant therapy is, of course, reduction of risk of relapse and increase of overall survival. It's necessary to correctly evaluate the risk of disease relapses, balance benefits and risk. And neoadjuvant therapy has potentially to overcome adjuvant therapy in microscopic disease. Why? Because first, we attack the tumor when it still exists. We remove the tumor, but immunocompetent cells which learn this tumor are on site and protect the human organism. And what is also important, that pathological response can guide further treatment decision. When we look at the history, until 2010, we had only surgery plus minus adjuvant interferon with small impact on disease-free survival. But after adjuvant anti-CTLA-4 was introduced in US with improvement of overall survival, but after anti-PD-1, and now we have 2 trials with neoadjuvant or neoadjuvant anti-PD-1 or PD-1 plus anti-CTLA-4 with amazing HR as compared to adjuvant therapy. So we use the same drugs, but in different sequence, achieving much better results. So NADINA and SWOG trials are the trials with establish the novel standard of care. A very clever trial with pembro from its SWOG trial 1801. Instead of all cycles of pembro post-surgery in stage 3B to 4 disease as adjuvant arm, they used 3 cycles of pembro preoperatively per surgery, and after 15 cycles of pembro, and you see the difference. And also from NADINA results, when we look at the 2 courses of EP-Nivo, short period of time, only 6 weeks therapeutic lymph node dissection, and we're in major pathological response, no other treatment, or standard therapeutic lymph node dissection and adjuvant therapy. And you see event-free survival was improved 27%, HR 0.3, distance metastasis-free survival 23%. So amazing data. Moreover, pathological response is much better in the final evaluation as compared to overall response rate by radiology only. So in this situation, probably in the future, maybe we can also omit the full therapeutic lymph node section, removing only one lymph node and checking the response to the therapy. Very interesting situation, 60% of pathological complete or near pathological complete remission. So neoadjuvant therapy can really individualize the treatment, reduce the need for adjuvant therapy, reduce the timing of treatment, and generally improves distant metastasis survival and overall survival. And probably therapeutic lymph node dissection does not affect survival in this situation. So neoadjuvant therapy, now it's option. It's introduced also to ESMO recommendation. According to our results, you see that we can achieve the huge decrease of the tumor and better remove it. And surgical outcomes after immunotherapy are not related to the increased complications. Here are from our data, also relation to the pathological response. This is almost complete response after the 2 cycles of ipi/nivo, and also the surgical complications are not increased. So, moreover, in the future, probably in this group of patients with this complete pathological response, we do not need to perform the dense follow-up for this patient. So this is a new standard of care only for 20% of patients, of course, because only for clinically involved lymph nodes. However, this is very important situation. So what we got now? Adjuvant therapy is standard of care for micrometastatic disease and stage 2 BC. Treatment duration is longer, about 1 year, and maybe quasi-neoadjuvant therapy with personalized vaccine will be introduced in the future. For neoadjuvant therapy, it's about 20% with clinically involved palpable nodal mets. It's the opportunity to decrease treatment and to reduce surgery in the nearest future. But as I mentioned, collaboration is a key to the success, because we have to decrease these results and improve the real results, evaluating the impact of adjuvant and neoadjuvant therapy for the future. So thank you very much. Thank you, my team from Department of Soft Tissue Bone Sarcoma of Maria Skłodowska-Curie National Research Institute of Oncology, Poland, and thank you, Professor Gabriela Liszkaj, for invitation for this event.